Hey everyone, let's jump right into this explainer. Today, we're looking at your ultimate high-yield survival guide for mastering OB complications. Look, if you're prepping for the boards, you already know obstetrics can feel like a totally overwhelming beast. But here's the secret. Success is all about pattern recognition and knowing exactly what the nurse must do first in a crisis. We're going to use these slides to lock those critical safety alerts and prioritization traps right into your memory. Let's get started. Okay. Picture this. We're dropping right into a high-stakes clinical scenario. A client arrives in the ED reporting abrupt, sharp, right-sided lower quadrant pain and bright red vaginal bleeding. She says to you, "I missed one menstrual cycle, but I can't be pregnant because I have an IUD." Think about it for a second. What is the very first thing the nurse needs to suspect here? If you're screaming ectopic pregnancy at the screen, you hit the nail on the head. This is a massive priority alert. An ectopic pregnancy is when a fertilized ovum implants outside the uterus, usually in the fallopian tube. The reason this scenario is tested so heavily is because it can lead to a tubal rupture, which causes a fatal hemorrhage. Recognizing these early warning signs, even when the client swears pregnancy is impossible, is exactly how you save lives on the floor and crush prioritization questions on the exam. Here is our roadmap for today's explainer. 1. Hyperemesis and metabolic traps. 2. Gestational diabetes guidelines. 3. The preeclampsia to HELP pipeline. 4. Early bleeding and emergency alerts. And finally, 5. A rapid-fire NCLEX recap. Let's dive in.
Section 1. Hyperemesis and metabolic traps.
We really need to separate everyday morning sickness from dangerous hyperemesis gravidarum. When a client is experiencing excessive, prolonged vomiting well past 16 weeks, their body is literally starving. The absolute dead giveaway? Positive ketonuria. That is your buzzword. If you see positive ketones, it proves the body is breaking down its own fat and protein stores for energy. You might also spot an elevated urine-specific gravity and metabolic alkalosis, from losing all that stomach acid.
So the ultimate question is, what does the nurse do first? Well, first things first, keep the client NPO. Nothing by mouth until the vomiting completely stops. We have to give that GI tract a break. Next, you immediately start IV fluids, specifically lactated ringers, to rehydrate and fix those crazy electrolyte imbalances. And third, administer pyridoxine, which is just vitamin B6, to help knock out that nausea.
Section 2. Gestational diabetes guidelines.
All right, so gestational diabetes is impaired glucose tolerance that shows up during pregnancy. The crucial thing to remember here is the progression of treatment. Unlike type 1 diabetes, the initial management is strictly diet and exercise. You start with carb restrictions and kick counts. But, and listen up because this is a massive test trap, if glucose stays high despite the lifestyle changes, we start insulin. Actually, wait, let me emphasize this. We specifically avoid oral medications. Why? Because they cross the placenta and we do not want to risk harming the fetus. So remember the flow. Diet and exercise first, then insulin.
Section 3. The preeclampsia to HELP pipeline.
Hypertensive disorders are huge for prioritization questions because they operate on a really dangerous continuum. Both of these conditions involve elevated blood pressure starting after 20 weeks. But the one singular defining difference between gestational hypertension and preeclampsia? Protein in the urine. Gestational hypertension has no proteinuria. Preeclampsia, proteinuria is absolutely present, often with transient headaches and edema tagging along. Lock that difference in.
Now, you absolutely have to be hypervigilant for these severe warning signs. If blood pressure spikes to 160 over 110 or higher, or if the client complains of severe headaches, blurred vision, epigastric pain, or if you assess hyperreflexia, like ankylosing, that's a massive red flag. These specific findings mean the preeclampsia is getting severe and is dangerously close to crossing into eclampsia, meaning seizures or coma. This is literally a life-threatening emergency. Which brings us to an even more complex complication, HELP syndrome. Visually anchor this mnemonic into your brain right now. H for hemolysis, EL for elevated liver enzymes, and LP for low platelets. And here's the trap you must avoid. HELP syndrome is diagnosed purely by lab tests, not clinically. You need to actually see the anemia, the elevated AST or ALT, and the thrombocytopenia on their blood work to make the call.
Section 4. Early bleeding and emergency alerts.
Okay, buzzword alert. If a scenario mentions a client with prune-colored discharge, like dark prune juice,
paired with a uterus that's growing way too fast for the gestational age, you need to suspect a high datiform mole, also known as a molar pregnancy. It's an overgrowth of trophoblastic cells, and that prune juice bleeding is your undeniable, locked-in cue.
Let's loop back to our hook at the very beginning, our ectopic pregnancy client. If that ectopic pregnancy ruptures, the classic red flag is referred shoulder pain. You might be wondering, why the shoulder? Well, it's because massive internal bleeding pools in the peritoneal cavity, travels up, and severely irritates the diaphragm and the phrenic nerve. That nerve irritation shoots a sharp pain right up to the shoulder.
Now for the absolute worst-case scenario, a uterine rupture, often signaled by an acute sudden loss of fetal station or intense abdominal pain. If this happens, here's exactly what the nurse must do first. 1. Reposition the client laterally. 2. Slap on oxygen with a non-rebreather at 10 liters. 3. Start 2 large-bore IVs to rapidly pump in fluids and blood. You are basically fighting hypovolemic shock and rushing to an emergency C-section.
Section 5. Rapid Fire NCLEX Recap. Let's see what stuck.
Question 1. A client at 4 months gestation reports continued nausea and vomiting, prune-colored discharge, and a fundal height much larger than expected for her dates. What complication are we suspecting here? I'll give you a sec to pull that from your memory banks.
Yep, high datiform mole. I know you got that one. The prune-colored discharge combined with the rapid uterine growth was the absolute dead giveaway. Brilliant pattern recognition.
Final question, going right back to our initial case study from the beginning. Which finding is uniquely expected in a client experiencing a ruptured ectopic pregnancy?
You got it. A report of severe shoulder pain? Remember the physiology behind it? That internal bleeding irritates the phrenic nerve. Once you understand the underlying why, the symptoms just make sense and are impossible to forget.
And that's a wrap. You are officially ready. Crushing these complex OB topics is all about spotting the patterns, knowing your strict priority interventions, and understanding the physiologic why behind the symptoms. So I'll leave you with this final thought. Based on what we've covered today, what classic OB test trap are you absolutely never going to fall for again? Keep that focus, trust your knowledge, and go completely crush your next practice exam. Thanks for hanging out with me for this explainer.